Hello, my name is Lynn Gordon and I'm a Senior Lecturer for Radiotherapy and Oncology at the University of Hertfordshire. I'll be narrating this presentation for you, but with the video off for most of it so we can reduce the file size. But I thought you might like to see what I look like on this first slide. Understanding the nature of different cancers is key to understanding the role of radiotherapy in their management. So in this short lecture, we will explore lung cancer as an example of how radiotherapy is used in this battle against cancer. There are many aspects to consider when determining the best approach for management of lung cancer. By understanding the risks and causative factors, we are able to care for our patients more effectively. Different types of cancer arise due to different medical and social backgrounds of our patients, and so careful consideration of those and the effects they might have on an individual's health and well-being can also help us determine the most appropriate management options. In order to successfully manage lung cancer, we need to have in-depth knowledge and understanding of the anatomy of the lungs and surrounding organs and how they look normally on our diagnostic images in order to recognise a range of diseases, including cancer itself. By carrying out that range of investigations and tests, we can build a thorough picture of an individual in order to ensure that they can discuss the most appropriate treatment options with their clinicians. At the end of the session, I will give a very brief overview of the different options for managing lung cancer, of which radiotherapy is one. Do remember though, that if I'm teaching about lung cancer on our normal programme, I would normally cover this content in 6 to 8 hours, so this really is a brief overview. On this slide, we're going to explore the prevalence of lung cancer in the UK. The statistics used here come from the Cancer Research UK website and cover cases up to and including the year 2017. It does take a lot of time to collate and check the information, so we're always slightly behind. These institutions that produce this information draw it from a number of different sources, including cancer registry bureaus and different hospitals all over the whole of the UK. The purpose of collecting all this information is to help us determine the things that increase someone's risk of a particular cancer, to monitor the effectiveness of different treatment options, and also to predict future trends related to different cancers. What we can see here is that there are nearly 50,000 cases of lung cancer each year in the UK, and this makes it the third most common cancer after breast cancer and prostate cancer. When we look closely at lung cancer rates though, they have steadily been increasing from the 1950s and 60s up to the early 1990s. And this is when rates began to plateau, and then since then they've decreased overall by about 8%. This reflects a decrease in incidence in men of around 11% and an increase in women of around 15%, which gives us this net 8% decrease. We'll explore the reasons behind these changes shortly, but in the meantime, just have a think about why there might be this gender difference. There does also seem to be a clear relationship between wealth and smoking rates, with more cases being seen in poorer, more deprived areas of the UK. And there also seems to be some sort of demographic difference when we compare white populations to black or Asian populations, with white populations having higher rates of lung cancer than the others. So let's now have a closer look at some of the other factors that affect an individual's risk of lung cancer. Etiology is the word used in medicine to refer to the study of causes of disease. It is closely related to epidemiology, which tells us where diseases occur, and incidence, which tells us how many people will be affected. In most cancers, including lung cancer, the main risk factor for any patient is older age. As we get older, we accumulate more damage to our DNA. This damage over time accumulates so that even if we remove all other possible risk factors, the risk of lung cancer will be greater in older people when compared to younger people. The research evidence base tells us that 72% of lung cancer cases are caused by smoking. The overall duration of smoking activity is more important than the number of cigarettes smoked. So, although smoking 40 cigarettes per day for 20 years adds up to the same number of cigarettes as if you smoked 20 of them per day for 40 years, your risk is higher if you smoke across the longer time frame. This relates to the amount of DNA damage caused that accumulates over that period of time. And we know this because if someone stops smoking before they enter their older years, say before they hit 50, their risk reduces right down to about 4%, which is nearly the same as that of a non-smoker. The cumulative DNA damage is halted and the body's immune system repairs some of that damage. We know that some workplaces can be hazardous if workers are not given the correct personal protective equipment, or PPE. In the top image, you can see workers clearing a site contaminated with asbestos, fully protected with their PPE, because we know that inhaling asbestos fibres damages lung tissue and that can lead to cancer. In the bottom archive picture from probably the 1950s or 60s, the worker is cutting bricks with no protection. This way of working led to a number of respiratory illnesses, but the cancer-causing chemicals in the dust is what most likely caused the higher rates of cancer in brick workers. Current research activity and health and safety standards have led to the development of new materials to help reduce this risk. In the next slide, I'll give you a bit more information about the smoking risk. We have known about the risk of lung cancer caused by smoking since the early 1950s, when Sir Richard Dole published his key papers on smoking and cancer of the lung. In his early papers, he initially noticed that there was a statistically significant link between smoking and lung cancer, and he found this by asking patients about whether they smoked or not. In his later papers, where he explored the mortality of doctors who smoked, he made the link that smoking more for longer periods meant a higher risk of developing lung cancer. Crucially, he also noted that smoking behaviour was also linked to a range of other cancers, such as throat cancer, stomach and bowel cancers, but not only cancer, also to cardiovascular disease. This graph from his 1954 paper clearly illustrates that if you smoke more cigarettes per day, your risk of lung cancer increases. Even though the links with smoking were known from the 1950s, the big tobacco companies have continued to advertise. In the 1950s, film stars such as Joan Crawford and Ronald Reagan promoted cigarettes, in many cases extolling the health-related properties of a brand. And here we can see them both saying how mild particular cigarettes are and that they don't cause throat irritation. In the 1980s, more targeted advertising developed with brands such as Kim, which was a cigarette brand marketed mainly at women. The macho environment of Formula One began a long association with tobacco advertising from 1960, and this was before widespread banning of tobacco advertising began in the 1990s. These days, cigarette packets carry warning labels and are sold from behind closed screens, and we have heavy taxation, bans on smoking in public buildings, etc. And these have all helped to reduce overall smoking rates. However, we had a question earlier, didn't we, about why rates of lung cancer in women are still increasing. Before the 1960s era of flower power and female emancipation, it was unacceptable for women to be seen to smoke. From the late 1960s, though, with the equal rights for women movement gaining momentum, many women began taking up activities normally seen as male pursuits, and smoking was among them. Media representations of famous women in the media smoking have made it cool for women to smoke, especially teenagers. In this picture, you can see Miley Cyrus, pictured with a cigarette in her hand. Now, because there is a lag of around 20 to 30 years between when somebody begins their exposure to cigarette smoke and a cancer developing, it's only now in the last 10 to 15 years that we were seeing the results of people who took up smoking in their teens in the late 60s, early 70s, and they're now developing those cancers. Because the uptake of smoking was greater in the 1960s for women, we're seeing their rates increasing, and when we apply that time lag, that's why the rates are still increasing in women, and we're not seeing that plateau that we've seen in men. Because the men have reached the age where the messages about stopping smoking have got through, and so their rates are coming down. Overall, we're likely to see in the next few years a reduction of lung cancer rates across both men and women as the effects of taxation, the smoking bans and the advertising bans are felt. So in the next slides, we'll begin to explore the diagnosis and management of lung cancer. If you look at this graph, you can see the number of cases of lung cancer that are diagnosed at each stage of the disease in the UK, excluding Wales. And this is because Wales is under a different health system to the rest of the UK. The different coloured bars representing England, Scotland and Northern Ireland are coloured in different shades of blue. Stage 1 represents small cancers which have not spread to other organs, and stage 4 represents either large cancers or those that have grown into other organs or those that have spread further around the body in a process called metastasizing. The stage unknown doesn't mean that we don't know the stage because we haven't done the right investigations. What it means is that the records from which this data is obtained did not have the stage of the disease stated within them. So whoever wrote the patient's medical records didn't note down what stage their cancer was. What the graph is telling us is that well over 60% of cases are discovered at a late stage, which then makes them more difficult to manage. The reason they are discovered late is because the signs and symptoms of lung cancer can mimic other diseases. Another reason is that a tumour can reach quite a large size before it starts causing problems, as essentially it is grown into a large, empty cavity, in other words, the lung. On the next slide, we'll explore some of those signs and symptoms in more detail. As we saw on the previous slide, lung cancers tend to present at a late stage. The symptoms of cough and shortness of breath can happen with other illnesses like bronchitis or a common cold. So sometimes they're ignored because a person thinks they'll go away, or for some people they think it might be their smoking behaviour causing the cough. In general though, these symptoms will continue over a period of weeks, and it is when other symptoms start to kick in, like severe shortness of breath or they start coughing up blood, that the person will seek medical help. When someone suffers weight loss when they have a diagnosis of cancer, this happens because tumour tissue consumes a lot more energy than normal body tissue. So if a person carries on eating the same amount of calories as they would normally eat, they'll lose weight because their tumour is using much more energy, and so the amount of calories consumed by the person are going to be used up much more quickly. That means that the tumour then draws on the stored energy in the body that is stored in the fat in the body or in muscle tissue. And so when that fat and muscle tissue starts getting used up, that's when a weight loss is noticed by the patient. Other symptoms tend to develop as the tumour gets larger or spreads to other organs, and on the next slide we'll have a look at 3 of these. Now, clubbing doesn't refer to what you might get up to on a Saturday night. In medical terms, it relates to the appearance of the ends of the fingers and fingernails in people whose circulation of oxygen has been impaired. So it's something that can occur in a number of diseases, but it is very commonly seen in patients with lung cancer. The lack of oxygen causes changes in the nail bed, which over time leads to this appearance of the nails. They look quite shiny, they're very curved, and the bases of the nail beds look quite pink, and the ends of the fingers look quite swollen. Horner syndrome occurs when there is damage to or pressure on a bundle of nerves called the brachial plexus, and that sits just at the top of each of your lungs, just underneath your shoulders. Now, there is a rare type of lung cancer called a Pancoast tumour, and this develops in the highest part of the lung, what we call the apex of the lung. So if it presses on this brachial plexus, it will disrupt the nerve signals that plexus sends out, and it can send nerve signals down the arm or up the neck into the face. And when this happens, a number of symptoms can occur, and one group of those symptoms is called Horner's syndrome. This specific group of symptoms includes a droopy eyelid, constriction of the pupil, and lack of sweating on the face, all on the side of the body that's affected by the tumour. SVCO stands for superior vena caval obstruction. This happens when a centrally located tumour grows big enough to press on the large vein in the chest called the superior vena cava. So this is the big one that sits next to the main aorta, which is the big artery that comes out of the top of the heart and then goes down the back of the heart into the abdomen. The superior vena cava is the vein that sits right next to it, and then when the vena cava passes through the diaphragm into the abdomen, it becomes the inferior vena cava. So with the SVCO, the pressure slows down the circulation of blood around the body. So to compensate, the body tries to improve the blood circulation near the surface of the body, so what we call the periphery. The capillaries enlarge to try and cope with the extra blood being routed to the periphery, because the main central big vessels aren't able to cope because they're blocked by this tumour. So this is one of the situations we manage as a radiotherapy emergency, because these patients get very sick very quickly due to really severe shortness of breath, and they get very fatigued because of how hard they're trying to breathe when their lung capacity has been so limited. By giving radiotherapy to shrink the tumour, we can alleviate the circulation issues because we open up the superior vena cava, and this means that it eases the shortness of breath because more oxygen is being supplied to the whole body, and therefore the patient is not having to breathe so hard in order to get the same amount of oxygen in. So although this is not a way that we can use radiotherapy curatively, it does mean that we can vastly improve the patient's quality of life, and it means that whatever time they have left, because at this stage their lung cancer is going to be terminal, they're going to feel, at least for a few weeks, much better. Now, not all lung cancers will remain confined to the chest area. If a lung cancer is left untreated, then small clumps of cells can break away from the main tumour and enter the bloodstream, travelling around the bloodstream until they lodge in a capillary bed where they start multiplying into a new tumour. In another mechanism, the cancer cells might enter the lymphatic system and lodge in a lymph node, usually quite close to the original tumour. And in the chest, these lymphatic nodes will sit either side of the main bronchi that join up into the trachea, which is the main tube that you breathe through. This process of spread, where these cancer cells break off from the main tumour, is called metastasis. Now, if you have a look at the top image, this is of a brain scan, and it shows a patient with a type of lung cancer called small cell lung cancer at 3 different phases. So the first image on the left is when they were first diagnosed. The middle image is 4 months after they had their radiotherapy treatment, and the final image is 9 months after they had their radiotherapy treatment. And where you can see at the top, it says external beam 30 gray. 30 gray is the dose that was given to treat this patient. That's the radiation dose. We know that the brain is a common site for lung cancer to spread to, but we also know that radiotherapy can quite effectively treat metastasis in this area. So again, we might not be able to cure the patient, but we might be able to relieve their symptoms. In the middle image, which is a chest X-ray, the red ring highlights the main lung tumour, and the blue ring highlights enlarged lymph nodes on the other side of the chest, which are caused by the spread of the cancer. In a healthy person, the lungs would appear to be a fairly uniform dark grey. However, you can see just underneath the red ring that there is some light grey cotton wool-like appearance on that lung. It looks whiter than the top of the lung. And this is a typical appearance of fluid in the lung, and this would cause the patient to be coughing and perhaps have a very wheezy chest. The final image is a CT of the abdomen. And you can see lots of organs here, and I'll go through those for you. Now, the biggest wedge-shaped organ is the liver, and when you look at the appearance of the liver, you can see some kind of slightly darker speckles within it. It's a bit like a Dalmatian, isn't it, with sort of dark dots on a paler background. But unfortunately, this patient has got widespread metastases in the liver, and so each one of those little dark dots is actually a small tumour within the liver. The other things that you can see on this image are at the bottom of the image with the point going down. That is what the vertebra looks like on a CT scan. And then just above that you can see a really bright white circle, and that's the main artery in the body called the aorta. So that carries all the blood from the heart down into the abdomen and to the legs. Just to the right on your image, which would be the left of the patient, on that right hand side, just to the right of the aorta, is a big white blob, and that's actually the bottom of the stomach. And the reason it appears white like that is that because the patient has been given something called contrast media during the CT scan examination, and that shows up blood vessels and fluid very brightly on a CT scan. The final big organ that you could see at the back there that looks a bit like a sausage sitting at the back of the chest is actually the spleen, and the spleen has a really vital function related to immunity in the body. Now around the stomach and the spleen and just at the bottom part of the liver you can see some very black areas. Now on this CT scan, anything that is quite dense appears white, and anything that is less dense appears black. And so those black areas are air, which means that what we're looking at there are the bases of the lungs. Now, as I said earlier, it's important that we differentiate lung cancer from other lung conditions so that we can make sure the patient gets the right diagnosis. So on this slide here are a few different diagnoses that could give similar image appearances to lung cancer. So the first one on the left-hand side is bronchiectasis. And bronchiectasis is a long-term chronic condition where the airways of the lungs become abnormally widened, and this leads to a build-up of excess mucus within the lungs. If there's lots of mucus and fluid in the lungs, it means that people can more easily pick up an infection, which would then add to that mucus and fluid. Because of the mucus and fluid, these patients often have what we call a productive cough. This means that they produce or cough up gunks from the lungs quite regularly. Remember what I said earlier about healthy lungs appearing dark grey or black on an X-ray. So take a look at the image of the patient with pneumonia. The lung fields are light grey and white in places, and this indicates a massive amount of fluid, mucus and infection within those lungs, especially the lung that on your image is on the left hand side but is actually the right lung of the patient, and it's actually smaller than the one on the left, which means it's undergoing collapse due to all of that infection. Now there are a number of different diseases and infections and viruses that cause pneumonia, and I'm sure that you've heard about this in the press this last few weeks related to the coronavirus. So with this amount of fluid and infection present in the lungs, this patient would find it extraordinarily difficult to breathe, and this is where they might need assistance via a respirator or a ventilator. They would not have enough lung volume to breathe on their own, and so it would need to be mechanically aided. So when we say the word pneumonia, what we're referring to is just an umbrella term that refers to any severe lung infection. Now, aspergillosis is a very interesting condition, and this is something that is caused by breathing in mould spores that are around us everywhere in the air, but more commonly present in poorly ventilated or damp environments. Now, healthy people won't usually be affected by aspergillosis, but people who have chronic breathing difficulties like asthma can be more at risk because they'll not be able to expel the mould as they breathe. The arrows on this image point to cysts of infection caused by the aspergillus mould. And what you can see is that those could easily be mistaken for tumours within the lungs because the rest of the lung fields are actually quite dark and clear. So it's really important that our radiologists learn these image appearances so they can diagnose the patients correctly. The final image is of a patient with tuberculosis. Now, if you've ever read a historical novel or watched something like Poldark on the telly, this is the disease that used to be called consumption up until about 100 years ago. It's highly contagious and causes fibrosis and scarring in the lungs, and this is indicated by the white cloudy appearance on this X-ray near the top of the lungs. The white arrow is pointing to a pocket of infection nearer the base of the lung. Now, widespread BCG vaccination, and you might have had this at school, has reduced the number of cases in the UK, but worldwide tuberculosis has been the infection that has caused the biggest number of deaths from respiratory infection. However, unfortunately, that's now being overtaken with the recent coronavirus outbreak. So having looked at some differential diagnoses, let's have a closer look at some lung cancers. So we can see 3 chest x-rays here, and the reason I've given just the chest x-rays is so that I can show you how different the appearances of lung cancers can be. On the left-hand image, this lady has a main tumour in her left-hand lung, which is on the right-hand side of the image as you're looking at it. So imagine she's facing you. You can also clearly see the outline of her breast tissue, and then there's also a bubble of air in the stomach just underneath the diaphragm, again on the right hand side of the image, and you can see it as a kind of a circle with a thin white line around it. So the thin white line at the top is the diaphragm, and then that bubble is air in the stomach. So this patient probably needs a decent burp. There's also a very small tumour which is quite circular in the other lung near the centre, and then at the top of that lung, so that, don't forget, is the right lung, there's another tumour near the centre. Now these appearances are typical of a very aggressive type of lung cancer called small cell lung cancer, and the reason this is aggressive is because it tends to have lots of different tumours popping up at the same time within the lungs. They're all primary tumours, they're not metastases, but those tumours then do go on to metastasise quite rapidly and early in the course of the disease. So this makes it a very aggressive type of lung cancer, and it's one that we need to treat very aggressively in order to help the patient. The middle image is a patient who has a different type of lung cancer called non-small cell lung cancer. So it sounds really silly, but that's the way lung cancers are classified. They're either small cell or they're non-small cell. And this is because small cell lung cancers need very aggressive systemic treatment, so we treat the whole body to make sure we've got everything treated, whereas non-small cell lung cancers in the main should be able to be treated locally, so we just treat the tumour itself and not the whole patient body. So you can see this middle image, we've got that spherical tumour in the middle of the left lung, so on the right side of your image as you're looking at it, just above the heart shadow, and you can see that it's quite spherical, it's nicely what we call circumscribed, and we would be able to focus our radiotherapy on that quite easily. It's quite near the centre of the chest, so maybe it might not be amenable to a surgical treatment approach, but we're going to come on to treatment modalities in a moment. On the right hand side we have the typical image of a Pancoast tumour, and we've talked about these earlier, so just to refresh, these are tumours that appear in the apex of the lung, so right at the top of the lung, and these are the ones that might press on the brachial plexus and cause a syndrome called Horner's syndrome. Now there's also some cloudy appearance at the bottom of the lungs and in the middle of the lungs, and this might indicate enlarged lymph nodes or infections, but it's very difficult to tell on this image. So now we've considered risk factors, diagnosis and image appearances of lung cancers. How do we treat them? Well, first of all, each patient will be assessed to find out how generally fit and well they are. We might need to take their age into consideration because older people might not tolerate some of the more aggressive treatments just because the body as it ages is less resilient and doesn't bounce back and heal quite so well. We might need to consider whether they have other health issues, what their surrounding support network is like, but mostly important, one of the most important things that we need to consider is what that patient's opinion is about the options available to them. So when all these considerations have been made, a decision is then taken about whether surgery, radiotherapy or chemotherapy, or indeed a combination of all of these or some of them, is the most appropriate management choice for a particular patient. Now on the left hand side of this slide you can see an image of 4 sets of lungs, and these images are indicating different types of surgery that could be carried out. Now, surgery is only possible for patients whose cancers are small and that occur away from the centre of the chest and where the heart and main blood vessels sit, and then only if they are fit to have an anaesthetic and are likely to cover well from major surgery. The surgery can range from taking a small part of the lung and the tumour to removing a whole lung. The middle image shows an image of a planning computer in radiotherapy, and so what it's doing here is comparing proton treatment on the left with intensity modulated radiotherapy on the right hand side. But in both of these planning images, the red colour indicates where the high dose of radiation would be received within the chest, and the green and blue areas are where the patient would be receiving a lower dose. And so part of a radiographer's role is to learn how to produce these images and make the plans ready for the patient's treatment. And so it does involve an awful lot of in-depth knowledge and understanding of the anatomy of the chest. So highly accurate planning is required to make sure that this dose not only sits over the tumour and make sure that the tumour is treated adequately, but also we need to make sure that we're not treating too much normal tissue and we're avoiding organs, what we call organs at risk. So organs that if we treated through them could cause severe damage to the patient. And so in the chest area, the most important organ at risk is the spinal cord. And on the image, you can see that there's a big white blob at the bottom of the image which represents the vertebra. Within the vertebra is a darker kind of upside down teardrop shape, and that's the spinal cord, or the aperture that the spinal cord sits in. And so we want to avoid dose to that region if we can, because what we don't want to do is give radiotherapy that then paralyses our patient because the spine is receiving too much dose. So the point of making sure that we don't treat any organs other than the tumour is that radiation treatment does cause sometimes severe side effects, and by minimising the dose to those surrounding organs we can make sure the patient has less side effects and therefore they can cope with the whole course of treatment. Lower side effects also means that the patients recover quickly. Now, chemotherapy is used when a patient has cancer that has either already spread but has the high potential to spread, like the small cell lung cancers do. So this is a treatment that is given in drug format, so it's popped into a drip and fed slowly into a vein. And some chemotherapy drugs can be given in tablet form as well. So whichever form they take, eventually the drugs get into the bloodstream and circulate through the whole of the body, and when they hit the cancer cells, they cause damage that those cancer cells can't recover from. Now, they're also going to be exposing normal tissues to those drugs, but the difference with normal tissue is that it has a better capability for recovery than tumour tissue. So the idea is that by treating either with radiotherapy or with chemotherapy, you're destroying the tumour tissue. You might damage a bit of the normal tissue, but in the end, the normal tissue will grow back and the tumour will shrink away. Now, not all treatments will get rid of all tumour cells straight away, so this is why we combine the different treatments, or patients might have treatment over a course of time. So this is why the decisions are made on an individual basis, guided by the most up-to-date research evidence that's available to the clinicians at that time. Now, one thing I forgot to mention on the previous slide is that alongside all these active treatments is the supportive care that a patient might need. So this could include pain management, anti-sickness management, social care support and psychological support. But again, all this is tailored to the individual. Now, once the patient has had all these treatments, we're hoping that they're going to have some sort of good outcome. So what are the outcomes for people with lung cancer? We can see on the left-hand graph that people with early stage lung cancers are more likely to survive than those with late stage cancer. So at early stage, stage 1, 80% of patients can be expected to survive. But look what happens when we get to stage 4. Less than 20% of patients who are diagnosed with stage 4 cancer, lung cancer, are likely to survive. And so this is why it's really important to educate people about their risk factors so that they can reduce their chances of getting lung cancer in the first place. But let's just refer to that graph on the right hand side, which is the one I showed you earlier about when different cancers are diagnosed. They're mostly diagnosed at this late stage. So there's a little bit of a problem here in that we know that patients will survive better if they're diagnosed at early stage, but unfortunately the majority are diagnosed at a late stage. So if we can teach people how to recognise the symptoms and get their diagnosis earlier, it really will help to save lives. Now I've come to the end of my presentation. I hope you've enjoyed what you've learnt about lung cancer, and I do hope you remember it. We won't look at lung cancer again probably in any great detail until the second year of our programme. That's where we look at lung cancers in a lot of detail. But if you're interested and you want to do some further reading in the meantime, then here's a couple of suggestions. So firstly, explore the Cancer Research UK website. That's where I got most of the statistics and images from for this presentation, and the Cancer Research UK charity does give permission for academics to do that. You can also explore really good quality websites such as the Macmillan Cancer Care website. And if you're interested in looking at other types of cancer, then a really good one is Prostate Cancer UK, which is, although it's a charity website, they have great resources, both for patients and for healthcare professionals about a range of issues related to prostate cancer. So just get a feel for other types of cancer and how they're treated. And I've just spotted a few really horrible spelling mistakes in this page, so I do apologise for that. Once you've had an unconditional place confirmed at the university, so some of you might be sitting at conditional stage at the moment, but cross fingers, at some point we'll be converting you to unconditional when you've met your conditions. Then you'll need to think about what happens when you join us in September. So we will be sending out a nice reading list for you. So a good book to start with, and I would recommend this as a purchase, even though it's expensive. It's about £80 I think, but it is a good thick textbook and it contains an awful lot of really great information, and it's something that you'll use throughout the whole of your 3 years on the programme, so it's a really good investment. And that's Walter and Miller's Textbook on Radiotherapy. Interestingly, the authors are Simmons, Mills and Duxbury, but that's because it's on its 8th edition and the original book was by Walter and Miller. Finally, my best advice about preparing for university is enjoy your summer, because we're going to keep you very busy once you join us. So again, I hope you've enjoyed this presentation and I look forward to meeting you all again later in the year.